Hey, can you see me? Hear me?
Yes. Yep.
Oh, I do you have your camera?
Oh, not yet. I didn't
Oh,
start it yet.
okay, that's fine. Okay, cool. So we will get started here in a little bit.
2 minutes.
We're live. It's already live right now. So
Yes.
okay, cool.
Yep.
So then I
Um,
will so those that are watching right now, I'm gonna get onto my computer as well too. So those that are already watching right now, myself and Nurse Brittany are gonna be teaching. Nurse Brittany, where are you at? I can't see you. Um, myself and Nurse Brittany will be teaching today, and we'll get started here in a couple minutes. But I will be handling the chat. So those that have questions during the chat, I will be doing that. So we'll give it a couple minutes, or actually a minute, and I'll just grab my computer so I can respond to people, and then I'll jump in
awesome.
as needed.
Sounds like a plan.
Cool. All right, then just give me 2 seconds, and I'll be ready to rock.
Perfect.
All right. So welcome to another free weekly Zoom. So today we're gonna be doing a little bit of med surge. We're gonna start off with a little bit of renal. We're gonna get into some cardio, super high yield stuff. Again, the stuff that we do is always high yield, so nothing new that we haven't topics wise, because you can't really change the systems, but the questions we definitely do change up, so that way you can watch some of these questions and see the content that you've learned, how we're going to be able to apply it as well too. So with that said, myself and Nurse Brittany, how you doing today?
Good. I'm
It's
doing well.
how's the weather over on the northeast?
Yeah, it's cold.
To say the least, to say the
I'd
least.
rather be elsewhere.
Well, I mean, Vegas hasn't been too bad, I'm not gonna lie. But nonetheless, with that said, let's do a couple of announcements before we get started here. Congrats to all of those that have recently passed. We're super excited. And your testimonies will be going up. If you need a financial assistance letter, again, utilize it, please. I know times are tough. Please, we've written it out for you. One-on-one tutoring. The best way to work with the tutor on the material that we teach you is to use one of our tutors that you've that have been in your position. So again, those tutors are exactly where you're sitting right now and watching. They've been through the program. They know all the different things that NCLEX High Yield, Ask Graph, Ask NIPA needs, the method, next gen questions. So make sure you're working with the proper tutor. All these tutors have been trained by me. I've been trained by Stanford School of Medicine to teach medical education. They've all been in your shoes. They've all crossed over to the other side. So make sure that you utilize them as well. Two free resources. Well, we love the word free. So utilize our free resources, podcast, YouTube, those of you that are joined here. Utilize all the free resources. Instagram, free questions on there. TikTok, even YouTube Shorts. We're all over there. So go ahead and do that. Self-paced online videos, they are being updated as we speak. Those of you that are in there, it is going to be a subscription base unless you're in the course and you have an extended period as well. We do have a 6 month all-inclusive package. What does that mean? Well, if you're debating on 3 months, 4 months on taking your exam, especially with the holidays coming up and you kind of want to pace it out, the 6 month is a great deal because it includes your monthly subscription. It includes 3 hours of tutoring with one of our tutors. It includes all the workshops. It includes checking in, all the downloadable notes. What else comes in it? And 6 months worth of access, and you're constantly enrolled. You're enrolled into every single course that we have. So you don't even have to ask, you'll be enrolled in all that stuff
Did
automatically.
you mention, Dr. Zishan, the check-ins and the complimentary CPR interpretation and the group studies?
No, I did not. So thank you for that. CPR reports are, we will interpret them as well too. And then if you, so even if you have a CPR report without your, without the 6 month all inclusive, ask us how you can submit your CPR report because we can 100% give us our interpretation of them and kind of guide you, whether you're already a student or you're looking to become a student, or you just tested and just want to get some insight. I look at those CPR reports and I'm like, what do they mean? They're so, as people love to use, they're not specific, they're vague. Just like apparently some of those NCLEX questions as well. So let me tell you and break those down for you. Those that have talked to me, put it in the chat. Like y'all know that I really do pick up the phone and call. And there's Brittany really picks up the phone and calls. People are like, for real, is this Dr. Z? And I'm like, do you hear my annoying voice? Yes, it is me. It is Nurse Brittany. Now, just submit your CPR reports. You can go ahead and we can schedule that out as well too. Those, of course, are going to be included with the 6 month all inclusive package. You also get a letter of recommendation. We are your reference. We can help you try to get reimbursed as well too from your upcoming job. We do have a 4-day live course coming up. It starts here a week from tomorrow. It's an amazing course. It's going to be 4 days, 8 hours long a day. It is taught by myself and there's Brittany. This course is going to be, there are going to be new notes involved. There's going to be a little bit of new content, some new questions, so on and so forth. So make sure you join. You do get 60 days worth of access to your self-paced online course. All of it's all updated. There is a scholarship. There is a scholarship. So if you are looking to get some financial assistance, this is what NCLEX High Yield is offering, a scholarship towards that live course. So submit your information, and our scholarship committee will go ahead and choose the recipient of the scholarship. And again, our free resources, please, please, please utilize them. Take advantage of it. And again, we do pick up the phone and call you. So if you have a question, just scan this QR code, reach out to us, Instagram. There's Brittany, if you want to type out contact@nclexhighyield.com.
Yes.
Why don't we just do that? Just contact@nclexhighyield.com. If you have any questions, we will. If you want to put that in the bottom and just leave it up in there. That way people have any questions, please feel free to reach out to us. With that said, what else? Anything else that we need to do?
I think that is it.
Oops, I'm dropping stuff over here. So I will go ahead. Free Zoo. Okay, so I got a couple of people that were asking questions. Stanford, yes, I did get certified in multiple things from Stanford School of Medicine. So thank you for recognizing. I worked hard for that. So yes, I did. Okay, so what time? Free session for new grad interview. Ooh, yeah, we're gonna work on that as well. Nurse Shakina, congratulations on passing. And by the way, love that you're still part of the community. It's so awesome to see people that are still with us. And good luck, Nurse Boom Number. And let's get started, Nurse Brittany.
Okay, awesome. Let's just get this
If
clear.
you have any questions in the chat, go ahead and put them in there. It could be anything. I'm going to be available to answer questions while Nurse Brittany is leading the lecture today, and I'll be jumping in to bother and interrupt as I do so well. Thanks, Nurse Brittany.
Okay, so let's get started. So we're starting here with a bow tie. So we have a 45-year-old male presents to the emergency department with severe intermittent right flank pain radiating to the groin, nausea and hematuria. The patient reports a history of similar episodes over the past year. He denies any fever, chills, or recent trauma. Okay, so nurse's notes. Pain assessment is 8 out of 10. Pain described as sharp and cramping. Vital signs, blood pressure of 145 over 90. Heart rate of 95 beats per minute. Respiratory rate 20 per minute. Temperature of 98.6 degrees Fahrenheit. Urinalysis is positive for blood, negative for nitrates and leukocytes. Lab values, white blood cell 8,000, BUN 20, creatinine 1.1, and calcium 10.2. Okay, so complete the following diagram by writing the correct choice from below to specify what condition the client is most likely experiencing, 2 actions the nurse should take to address that condition, and 2 parameters the nurse should monitor to assess the client's progress. Okay, so let's get started with condition most likely experiencing. We have urinary incontinence or bladder cancer. What are our thoughts? What do we want to narrow it down to? Let me open up the chat here so I can see.
So the problem with the chat, Nurse Brittany, is that there's a lag time.
Oh, okay.
So
Very
you're
easily.
just gonna have to go through it.
Okay,
Unfortunately, yeah.
that is totally fine. Okay, so typically I like to start with option 4. We compare it to 3, we get rid of 1. Let's just kind of let's go through, let's go back to, let's break it down together. So this guy comes in with this severe flank pain, right? It's intermittent, it radiates to the groin, plus he's got blood in the urine, right? No fever, no chills, and his urine was clean from infection, right? That's a huge clue that this is not what? Not a UTI or infection, right? Pain that comes and goes like waves, that's what we call colicky pain. And it's classic. Does anyone know what it's classic for? Kidney stones. So basically, the stone moves through the ureter and causes these intense spasms as it's trying to pass. And his calcium of 10.2, which is on the high end of normal, right? And calcium stones are the most common type. So all signs here are pointing to renal stones. So I would go with option 2 here, renal stones. Now, what are we going to do, or what do we have to do for this patient? Let's see our answers. So educate the patient on straining urine to catch any past stones, encourage increased fluid intake, prepare the patient for a CT scan of the abdomen and pelvis, administer prescribed analgesics. So I would encourage those fluids. We want to wash, or not wash, we want to flush that stone out, right? So more fluids, more urine, there's a better chance the stone will pass. If they can't drink because of nausea, then we go to IV fluids. And then I would administer prescribed analgesics. We'd give pain medication, right? The pain is next level. It's probably one of the worst pains that you can have. And the goal is to get that pain under control so the patient can relax and not go into that panic mode or panic response. When you relax the body, the ureter can also relax. And that'll make it easier for that stone to move through. So pain control is definitely a priority here. And then, Dr. Zishan, do you want to add anything in?
Yeah,
Okay.
I was just gonna add in when we're looking at if you want to go up one slide, I just want to address a couple of
Yeah.
things. So one is when we look at the blood pressure, obviously it's a little bit elevated, but the big thing is the UA. The UA is indicative of obviously something um, that's abnormal, and that is the blood. The hematuria is huge, and the negative for nitrates and leukocytes. So these are clues, and we really have to pay attention to the clues when we're dealing with bow ties case studies in general. So now we go down into the diagnostic portion. Right off the bat, you should be able to rule in two of them, rule out one of them. So, or sorry, rule out two, rule in two. Just from the hematuria, and the first one is going to be renal stones, and the second one is going to be bladder cancer. Both of those can potentially have hematuria in it. So those two you rule in. The fact that there's no leukocytes or no nitrates, we can rule out UTI. And the fact that there is blood, we can rule out urinary incontinence. So you're already down to 50-50 in this situation. And as Nurse Brittany was saying, yes, 100%, we are looking at that pain. Pain control is huge in stones.
Oh, was that all, Dr. Zishan?
Yep.
Oh, okay. I'm sorry. I didn't want to cut you off. I thought you were still going. So now what do we have to keep an eye on? So, renal function, BUN and creatinine levels, urine output and presence of stones in the urine, signs of urinary obstruction or infection, and then we have option one, pain level and response to analgesics. So I would go with the option one, pain level and response to medications, right? You're constantly reassessing. Is the pain getting better? Is it staying the same? Is it worse? If it's getting worse or they stop peeing, that could mean the stone's blocking the ureter completely. And that's a problem, right? And then the other one I would go with is urine output and presence of stones in the urine. You will want them to use a strainer when they pee so that you can catch the stone if it passes. Also, you're watching to make sure they're still making urine. If there's no urine output, that is a red flag. There could be an obstruction. So, like Dr. Zishan was saying, it's not a UTI. Why? Because there are no nitrates or leukocytes in the urine, right? UTIs can also cause burning or urgency, not radiating pain, right? It's not pyelonephritis, right? There's no fever, there's no chills. Pyelo patients look sick. And it's not trauma. He denied injury trauma. The pain comes and goes. Trauma pain doesn't do that, right? So if the question gives you flank pain radiating to the groin, plus that blood in the urine, you're thinking renal stones. If it's flank pain and fever and chills, now you're looking at pyelonephritis, ASCRF, right? Makes sense. Okay, there we
So
go.
yeah, and I think that this is a really good question. Now, let me give you a little point of where to study. When it comes to renal, a couple of things that we want to focus on is obviously the differentials that we talked about: bladder cancer, bladder incontinence, UTIs, and what we're dealing with here is stones. So renal is one of those ones where there's a lot of, and we look at those CPR reports, and those of you that are repeat test takers and or are getting ready to take your first attempt, remember this, that management of care and basic care and comfort, these are two of your 15 criteria on your CPR report. Those are arguably the most heavily weighted topics. Tell me where we didn't talk about management of care of renal stones and also your basic care and comfort. Of course, you're going to do basic care and comfort, manage their pain, encourage fluids so they can potentially pass them. And then on top of that, we're looking to see if that basic care and comfort of the analgesics is actually working. Isn't that just managing their care? So is monitoring their urine output and the stones. So now we're looking at parameters to monitor, which is just to select all that apply. But again, you can see we're going to do management of care and basic care and comfort in literally every subject. So if you don't kind of look at these topics in that mentality, and that's what the boards are looking at because in real life, this is what you're going to be doing. So again, this is in fact management of care and basic care and comfort, along with the analgesics. You know the type of analgesics that you're going to do depending on the situation. Well, what can I give them, Dr. Z? Well, look at pharmacological interventions or therapies are huge on the boards as well too. Again, know your farm. So sorry, that was all my input right there.
Okay, awesome. Okay, so let's see. Which patient should the nurse assess first? A nurse is caring for 4 patients with heart failure. Which patient should the nurse assess first? Let's see our options here. So option D, a 60-year-old patient with heart failure experiencing confusion, agitation, and a sudden increase in dyspnea and productive cough with pink frothy sputum. Option C, a 70-year-old patient with heart failure who has developed a persistent dry cough and an elevated serum potassium level of 5.5. Option B, a 68-year-old patient with heart failure who has a B-type natriuretic peptide, BNP, level of 1200 and has gained 5 pounds in the last 2 days. And then option A, 74-year-old patient with chronic heart failure who reports a new onset of orthopnea and needs to sleep on 2 pillows at a time. What are we leaning towards here? I'm leaning towards the 60-year-old patient with heart failure that's experiencing this confusion, agitation, a sudden increase in dyspnea, and that productive cough with the pink frothy sputum. This one should make your nursing radar go off immediately. They are confused, they're agitated. So, what is that pointing to from ASCRAF? Altered mental status, right? They also have pink frothy sputum. That's fluid coming from the lungs, meaning pulmonary edema, or fluid backing up into the lungs from severe left-sided heart failure. So this patient's in respiratory distress, right? Which affects airway, it affects oxygenation, right? That's our number one priority, airway. So not only does it fit airway, it also fits altered mental status, it also fits airway, right? So this patient could literally crash if we don't see them first. And then do you want to add anything in there, Dr. Zishan?
Yeah, I just want to kind of point out a few things.
Yeah.
This is a great question, by the way, because as we use the method, so let's go through the method for those of you that were a little bit concerned. Yes, we're looking at that altered mental status, that confusion, agitation, or a potassium level of 5.5. Again, that you're going to see ones where you're kind of concerned about it, but we are dealing with what type of heart failure when we're talking about the confusion. As Nurse Brittany said, this is left-sided heart failure. And the potassium levels, again, we're not dealing with any palpitations, cramping, any dysrhythmias, but what's the difference between B and D? And that's kind of where I want to chime in. We do have a BMP of 1200. 1200. That is super high because above what level is abnormal? Above 100. Above 100 is abnormal. In that 400 to 600 range, depending on where you read, we're kind of concerned about it. But in this situation, they have gained 5 pounds in the last 2 days. Could this be right sided heart failure? Yes. Could this be biventricular heart failure? Yes. Could this be left sided heart failure? Yes. So in this situation, they're not telling us that this is airway compromise, which is what's happening in D. So if you said airway or you said altered mental status, either one of those from AskGraph is completely okay with me. But ultimately, you're seeing this as a situation where we are freaking out about it. With B, we don't necessarily feel that way. And again, that orthopnea needs to sleep with pillows, not as concerning.
All right. So yeah, when you see pink frothy sputum, think pulmonary edema, not just heart failure. It's the lungs drowning in fluid, and your job is to get oxygen on board first, than diuretics like furosemide. And remember, airway beats everything, right? In priority questions. So ask graph doesn't go in any particular order, but airway is always number one, right? Okay, there we have it. Okay, which patient should the nurse see first? So another priority. The nurse receives the following lab results for 4 patients with heart failure. Which patient should the nurse see first? So who are we freaking out about the most here? Option D, a patient with a serum creatinine level of 3.0 and reports of decreased urine output versus option C, a patient with a serum sodium level of 125 and mild confusion. Option B, a patient with a serum potassium level of 6.2 and generalized muscle weakness. And option A, patient with a BNP level of 1500 and no new symptoms. Which are we leaning towards? I think that I'm leaning towards the patient with that serum potassium level of 6.2 and that generalized muscle weakness. What is this? Severe hyperkalemia, right? And potassium that high can literally stop the heart. Normal potassium is what? 3.5 to 5.0. Once you hit 6.0 or higher, we're talking about cardiac arrest risk. That muscle weakness is also your early sign that the heart muscle is being affected too. So this is an immediate life-threatening situation, right? These patients are going to need cardiac monitoring, right? Right away. Calcium gluconate to stabilize the heart. Insulin plus D50, right? Or sodium bicarb to drive potassium back into the cells. And Kxalate or dialysis to remove that extra potassium. I'm not sure if you want to add anything in there, Dr. Zishan.
No, I mean, just
Okay.
kind of going through it again. Well, actually, I said no, but I'm about to. Typical how my brain works. Yeah, so remember a couple of things, just points of content to remember so I can just highlight them. Serum creatinine, of course, we're looking at that 3.0. We're concerned about that because of the decreased urine output. Heart failure, remember we talk about that warm, red, oxygenated blood not making it to the kidneys, that kidney is starting to fail. However, just understand that we do have a little bit of time with that. With the serum sodium levels, this is one that students chose more than anything else because of the fact that 125 is significantly low. But we're looking at 120 and below. That's really scary. And that word mild, remember that word mild is very, very important. It's mild confusion. Yeah, are we concerned about it? Absolutely. Can we start to correct this? Absolutely, especially if they're on a diuretic or if we need to get them on a diuretic. Sorry, we can correct this, but the potassium can throw them into that ventricular fibrillation. So we have to be very very careful. So again, if you're comparing D to C, I'll probably go with C over D. If I'm comparing C to B, then I would choose B. And then now I'm down 50-50. And again, just like the previous question, that BNP is alarming, but as somebody had said in the chat, that 6.2 with signs and symptoms, we don't have a lot of time with. So, yeah, let's continue on.
Yeah. So when you see potassium that high, like that 6.2, your heart's in danger, right? And hyperkalemia kills through the heart, not the kidneys. That's why in Ascraf we have potassium, right? That's one of our red flags. So the muscle weakness here isn't just in the arms or legs, that includes the heart muscle. So this is the patient I'd run to first. Okay. Okay, so when we use the method, you'll notice that I'm reading the last sentence first. That's part of the method. The method is something that we use for every single question that we do. It's a way that we break it down. It just helps us to catch more detail too. So that's why I read the last sentence first, and then I go back and I read the entire question. And something that I find helpful is when you read the last sentence first, I like to put it in my own words, and then when I go back and read the entire question, I put it in my own words, and that's kind of what I throw on my whiteboard to be helpful. Anyways, which patient should be prioritized? So another prioritization question. A nurse is assessing 4 patients with heart failure on a telemetry unit. Which patients should be prioritized? So, who are we freaking out about the most? So, we have option D, a patient with heart failure who reports worsening fatigue and dyspnea on exertion with vital signs stable and within normal limits, versus option C, a patient with heart failure who has a blood pressure of 150 over 90 and reports occasional weakness. So D versus C, what are we thinking we'd keep around? You always want to start at the bottom and work your way up. You compare the two, you get rid of one, you work your way up. So between C and D, the heart failure patient with a blood pressure of 150 over 90 and occasional dizziness versus a patient with heart failure who reports worsening fatigue and dyspnea on exertion with vital signs stable and within normal limits, which one are we freaking out about more? I think I'd cross out D and go with C. With D, fatigue and the dyspnea on exertion, the vitals are, that's chronic heart failure. That's expected symptoms, right? This is the kind of patient that you teach about energy conservation, right? You're not going to drop everything for this patient. And then option C, the patient with heart failure who has a blood pressure of 150 over 90 and has that occasional dizziness. The blood pressure is a little high. It's not an emergency. The dizziness, it says occasional dizziness. It's likely from the meds or fluid shifts. I wouldn't say it's our first concern, but between D and C, I'd go with C. Then we work our way up, C versus B. So we have C, the patient with heart failure, blood pressure 150 over 90, the occasional dizziness, versus B, a patient with heart failure who has a heart rate of 105 beats per minute, reporting palpitations and lightheadedness with a history of AFib. Are we getting rid of C or are we getting rid of B? Which one are we freaking out about more? I'd cross out I'd cross out C and go with B. Um, so again, with C, the blood pressure is a little high. Again, not a big emergency. The dizziness probably from fluid shifts or from meds. With B, the heart rate 105 with these palpitations, lightheadedness, AFib history. So the patient's heart rate is slightly elevated, not critical. AFib with a rate of 105 that's controlled. We worry more when it's over 120 or if they're unstable, like if there's a low blood pressure or chest pain. So they're okay for now, which leaves us with option A, a patient with heart failure who has developed a new S3 heart sound and increased peripheral edema. So I would say this is our priority. Um, the heart is basically starting to fail more. An S3 heart sound is that lub dub dub that you might hear. It's not normal in adults. It tells us basically the left ventricle isn't pumping effectively. So fluid's backing up. And then that backup is leading to edema. And if we don't do something now, it can move up into the lungs and then cause pulmonary edema, which would become airway from ASCRAF, right? So the patient's not coding yet, but they're right on the edge. So you definitely want to assess and intervene now, before they start coughing up pink frothy sputum, like the patient in our other question. Do you want to add anything in, Dr. Zishan?
No, I think that this is great because the one thing that I do want people to take away, the rest of this between DC and B, we've talked about. So, what are some takeaways? And this is how I want you to study as well, too, right? The way that Nurse Brittany teaches, the way that I teach, is to show you how to break these questions down. But let's take this one step further. Remember, let's just say you saw this question and you were like, "Wait a minute, okay, I see the word atrial fibrillation in B." I want your mind to kind of start to wander a little bit, okay, and not into a tangent, but I want you to start to think, okay, atrial fibrillation. What did we learn about atrial fibrillation? Just start going back to that lecture. Just kind of think to yourself as you're studying, not on test day, but as you're studying, I want you to think, okay, cool. All right, atrial fibrillation, clotting, heparin, warfarin, bridging, so on and so forth, right? Look at, identify the irregularly irregular, no P waves. Okay. I want you to think like that just so you're kind of tying things in. But the really cool thing about this question is that it brings up the S3 heart sound, and that is indicative of fluid overload. So make sure you know these terms. Again, these clues are going to help you on test day. But no, that was an excellent explanation, Miss Brittany. Thank you.
Trying to unmute myself. Awesome. Okay. Nice. Yeah, so basically that S3 means the ventricle can't keep up, right? So fluid's backing up and we're seeing it in the legs, and the next stop's going to be the lungs. So the patient is basically sort of waving a red flag saying, I'm about to get worse. So that's definitely who you want to see first. Okay, so which patient should be seen first? Another prioritization question. You read the last sentence first. A nurse is caring for 4 patients with coronary artery disease. Which patient should be seen first? Option D, a patient who had a coronary artery bypass graft 2 days ago with a temperature of 100.3 and mild chest drainage. Versus option C, a patient with stable angina reporting a sharp chest pain ongoing for 2 hours and is relieved with nitroglycerin. Which one are we freaking out about more? Or which one would we keep in? I'd get rid of C and keep D in. So, a patient who had a coronary artery bypass graft 2 days ago, temperature 100.3, mild chest drainage, that's actually normal 2 days after surgery. You'd monitor it. It's not super urgent. You do want to watch for a risk of infection, right? That's definitely something to watch. But right now, there's nothing like we're super freaking out about here. And then versus C, a patient with stable angina reporting a sharp chest pain ongoing for 2 hours and is relieved with nitroglycerin versus B, a patient scheduled for a coronary angiogram today reporting anxiety about the procedure. I'd get rid of C here. With C, it's controlled. The nitro worked, right? The pain is gone. That means it's not an infarction, right? We can reassess them later, which leaves us with B and A. So option B, a patient scheduled for a coronary angiogram today, reporting anxiety about the procedure, versus A, a patient reporting new onset chest pain radiating to the left arm and jaw, not relieved by rest or nitroglycerin. Which one would we go with between B and A? I'm going towards A. With B, they're scheduled for a coronary angiogram today, reporting anxiety about the procedure. They're stable, right? I mean, anxiety is expected. It's not going to kill them. You could support them later. But right now, I'd say patient A, the patient with a possible MI, is going to take priority in my book, right? Option A is textbook myocardial infarction, a heart attack, right? There is radiating pain to the arm or jaw, right? Cardiac origin, and it's not relieved by nitroglycerin or rest. So it's not just angina, it's a complete lack of blood flow. It's a part of the heart muscle. So if a patient tells you their chest pain isn't going away even after nitro, that's kind of like your drop everything moment. Nitro works for angina, not for a blocked artery. So that patient can code any second. So the heart, it's not getting oxygen, and the brain and the organs are going to be next. So that's hands down my first priority, option A. There we go. Oh, do you want to add anything in, Dr.
Oh
Zishan?
yeah, this is no, this is perfect. I just wanted to reiterate that with this
Okay.
is a prioritization question, right? It is that first initial priority, urgent, most concerning, immediate report to HCP, and this is Ask Graph because that last H in Ask Graph is heart attack, right? So we are very, very concerned. Ask Graph. So utilize it, and then I just wanted to chime in on the chat.
Yeah.
Those that are using the method that are saying like A over B or C over D, amazing job. Like I said in the chat, the method won't fail you. It'll keep you organized throughout the process. So continue doing that. And put in your questions into the chat as well too.
Yep. Okay. Okay, so let's see. Which patient requires immediate attention? So another prioritization question, who are we freaking out about the most? The nurse is reviewing the telemetry readings and symptoms for 4 patients with coronary artery disease. Which patient requires immediate attention? So D versus C, a patient post-MI with shortness of breath and mild pedal edema versus C, a patient with CAD experiencing chest pain and a new ST segment elevation on the ECG. Which one are we freaking out about more? I'm freaking out more so about C. When you see ST elevation, you don't wait. That is a full-blown heart attack happening right now. The heart muscle isn't getting oxygen, and if we don't do something, part of the heart is going to die. So I'd get rid of D. I'd go with C. C versus B, a patient with chronic stable angina reporting a burning sensation in the chest while lying down. That's reflux-like or positional pain when you're lying down. That's not an emergency, not compared to that ST elevation in option C. So I'd still go with C between C and B. So I got rid of D versus C, I got rid of D. C versus B, I'm getting rid of B. That leaves us with C versus A. A patient with history of CAD experiencing new onset dizziness and palpitations with an ECG showing frequent premature ventricular contractions. Which one are we freaking out about more? I'm still going with C. So with A, PVCs can happen from low potassium, stress, caffeine. They're concerning, but I wouldn't say they're immediately life-threatening unless they turn into VTAC or VFib. So they more so need monitoring right now. I wouldn't say it's an emergent situation. So I would go with C. So again, if you ever see ST elevation on an NCLEX question, I'd say drop everything. That's your code patient. Do you want to add anything in, Dr. Zishan?
Yeah. Again, I think that premature ventricular contractions is kind of that distractor, right? We talk about distractors on the boards, and this is one of those things where you're like, "Whoa, frequent premature ventricular was a ventricle." But in all reality, they are mostly harmless. So, and as Nurse Brittany had mentioned, it is things like caffeine, alcohol, stress, nicotine. These are things that are going to cause that. So, they are one of those situations where we say, "What? Stop the offending agent." It is harmless. It is a distractor. It's one of those things that people are going to get. They're going to chase after a fraction of that entire sentence versus understanding the content here. So don't fall for the distractors, especially the ones that I talk about in the course.
Yeah. Okay. Which patient should the nurse assess first? So who are we freaking out about the most here again? Priority. A nurse is assigned to 4 patients with coronary artery disease. Which patient should the nurse assess first? So we have D, a patient with chronic angina who reports that chest pain has increased in frequency and is not relieved by rest but subsides with nitroglycerin. Versus C, a patient with CAD who had a coronary bypass surgery 3 days ago and now has a blood pressure of 95 over 55 and a heart rate of 92. Who are we freaking out about more? Who do we want to get rid of here? I would cross out both of these, but if I had to, I think I'd get rid of D, keep C around. So with the chronic angina who reports a chest pain, increase in frequency, not relieved by rest, but subsides with nitroglycerin, that's stable angina. It's controlled and relieved with that nitro. It's not an emergency. I'm not freaking out about it. Option C, the patient with CAD who had a coronary artery bypass graft surgery 3 days ago, and now they have a blood pressure of 95 over 55 and that heart rate of 92. That's low, but that's expected a few days post-surgery. They're recovering. They're not decompensating right now. Um, so I'm not really freaking out about that. But between D and C, I'd get rid of D, keep C. C versus B. A patient post-percutaneous coronary intervention, or PCI, 6 hours ago, reporting increased groin pain and swelling at the catheter site with a heart rate of 127 versus the C, the patient with CAD, who had the coronary artery bypass graft. Which one are we getting rid of? Or which one are we freaking out about more and keeping around? I'd say B over C. I'd go with B over C. So we got rid of D. I'd get rid of C between B and C. My reason being, so the patient PCI 6 hours ago reporting increased groin pain and swelling at the catheter site with a heart rate of 127. The biggest complication after a PCI is what? Bleeding at the catheter insertion site, especially in the femoral artery or the groin area. If you hear pain, swelling, or like a hard lump at the site, that's a red flag for a hematoma. That could be life-threatening. And the elevated heart rate, the 127, that's the body's way of trying to compensate for that blood loss. So even though there's no visible blood pouring out, this could be internal bleeding, H, hemorrhage, ass graft, right?
100%.
Right, you want to add
100%.
anything in, Dr. Zishan?
Yeah, no. This is a great question,
Yeah.
by the way. And the reason being is that I'm seeing in the chat that a lot of people are kind of mixed between C and B.
Hmm.
And I think it's great to realize that. And I did see somebody, and I'm going to say this as well, real quick. It says, "Oh, Nurse Chris, by the way, great observation. Nurse Chris had mentioned that this is in fact 6 hours in the patient in B." Which means that it's something sudden, it's acute. It's like, yo, what's happening? What is
Hmm.
going on with this patient? We are freaking out about this patient. Whereas in C, it is 3 days, and I did see that as well too with one of our students, Nurse Yolande, which noticed that it was 3 days ago, and now has a blood pressure of 95 over 55. Okay, that is a low, but is this hemorrhaging? Is this sepsis? No, our heart rate is fine, and then there's no other indication of anything else. Correct? Do you think by chance that maybe we did drop their heart or their blood pressure on purpose? Hmm. But again, who do we have less time with? What more can we do with the blood pressure of 95 or 55? Maybe like, and this is how I want you to think, because could we do the following? Could we give them fluids? Sure. Could we check their incision site? Incision site? Absolutely. Could we look at their medications and potentially stop or adjust the offending agent? Absolutely. But with the patient in 6 hours with that groin pain and swelling at the catheter site, it's not just ash graft. Take it one step further. It is, in fact, ash. And we're looking at this as hemorrhaging right away, as Nurse Brittany pointed out.
Okay, awesome. Okay, so what is the nurse's priority action? Prioritization again. So a 65-year-old male is brought to the emergency department by paramedics after collapsing at home. Upon arrival, he is unresponsive, pulseless, not breathing. The cardiac monitor shows ventricular fibrillation or VFib. What is the nurse's priority action? So, option D, insert an oropharyngeal airway and provide bag mask ventilation, versus C, begin cardiopulmonary resuscitation, CPR, and prepare to defibrillate. Are we going with C or are we going with D? I'd say C. I'd say C, begin CPR and prepare to defib. The patient has no pulse, no breathing, and is in VFib, right? That means there's chaotic electrical activity in the heart, right? But no actual pumping. So the first thing you do is you want to get that blood moving with CPR while someone grabs a defibrillator, right? CPR is going to keep the oxygenated blood flowing to the brain, to the vital organs until we can shock the heart back into a normal rhythm. So defib is the only thing that can fix VFib, right? Medications aren't going to fix a heart that's just quivering. So you do CPR plus defibrillate. That's the combo. So I'd go with C versus D. C versus B, administer epinephrine 1 milligram IV push. C versus B, I'd still go with C. I'd still go with C. Again, um, they don't have a pulse. They're not breathing. They're in VFib. So I'd still go with C versus B. And then C versus A, administer amiodarone 300 milligram IV push. Amiodarone's used after you've defibrillated and you've done the CPR cycles. You don't start with drugs when the heart is even circulating blood, right? It won't reach the heart anyway. Does that make sense? Let's double check. Awesome. So we go with C here. Would you like to add anything, Dr. Zishan?
No, the only thing I do want to add in is remember with CPR, if you got a CPR report, you can submit it to us. Different type of
Yes.
CPR, but just letting you know. Remember, we're looking at those CPR reports for you all. With that said, Ms. Brittany, I'm going to go ahead and take off. I need to make
Okay.
some calls to some students, so keep your phone on you. If you
Awesome.
see a 725
It's
444
Dr.
number, that
Zishan.
is me or Nurse Brittany calling you. We'll text you if we get your voicemail. All right, Nurse Brittany. I'll
Thank you,
talk to you
Dr.
later.
Zishan.
Thank you,
Thank
everyone.
you.
Thank you all for joining us and spreading the word. We
Yes,
appreciate it.
absolutely. Okay. Okay, so this is ventricular fibrillation or VFib. Um, if you take a look at this, it's a complete mess, right? There is no rhyme, no rhythm, no pattern. It is just chaos. And that's exactly what's happening inside the patient's heart. The ventricles are quivering instead of pumping, right? So if the ventricles aren't pumping, there's no cardiac output, meaning no pulse, no oxygen, no circulation. That's why the patient's unresponsive, they're pulseless, they're not breathing. The key thing with this is you cannot synchronize this rhythm because there's nothing to sync with. There's no R wave or organized pattern, right? So you don't waste time trying to sync. You grab the defibrillator and deliver an unsynchronized shock. That's defibrillation. And while that's being set up, someone else is doing CPR to keep the blood flowing. This is a true cardiac emergency, and your window is short. Brain cells start dying in about 4 minutes. So if it's chaotic with no pattern, that's VFib, and you defib. If they're in VFib, you defib. Make sense? Everyone got that? So if there's no organized pattern, there's no pulse, do not try to synchronize. You shock immediately. CPR and defibrillation, right? Unsynchronized cardioversion. And then medications like epinephrine or amiodarone come after CPR and shocks. Okay, so which of the following actions should the nurse take first? A 72-year-old female with a history of AFib, atrial fibrillation, and hypertension presents to the clinic for a routine checkup. Her current medications include warfarin, metoprolol, and lisinopril. She reports occasional palpitations and dizziness. The nurse notes an irregular heart rate of 110 beats per minute and a blood pressure of 140 over 85. Which of the following actions should the nurse take first? What are we going to do first, given the situation. D, educate the patient on reducing caffeine intake versus obtain an electrocardiogram. Which one are we keeping? Which one is more important? I'd say C, obtain an ECG. You can't treat what you haven't confirmed. The ECG is going to give us basically a snapshot of the rhythm so you know if this is controlled AFib or something new like AFib with RVR or even another arrhythmia. So this is about assessment before intervention. That's a huge principle on NCLEX, by the way. Versus the D, educate the patient on reducing caffeine intake. Yes, caffeine can trigger palpitations, but I wouldn't say this is the time for teaching. Teaching is going to happen when the patient's stable, not dizzy and symptomatic, right? So C versus B, administer a prescribed dose of digoxin. You do not give meds until you've confirmed what's happening on the monitor. If her heart rate is 110 and she's just mildly symptomatic, that's not just like automatically give digoxin. Also, giving cardiac meds without an ECG could actually make things worse if it's not actually AFib causing the symptoms. So C versus A, check the patient's international normalized ratio or INR. That's important for someone on warfarin, not the priority right now. She's having new symptoms, right? Dizziness, palpitations. That could indicate a rhythm or rate change. So you can check the INR later once she's stable, right? So whenever a question gives you a cardiac patient with new or changing symptoms, before you give meds, before you draw fluids, before you call the doctor, always think get the rhythm strip first. Make sense? Everyone got it? Awesome. Okay, so let's look at what AFib looks like on an ECG here. So the first thing you'll notice, there are no P waves. Those little bumps that usually come before each QRS, they're gone. Instead, you see these little squiggly waves between the QRS complexes. That's called fibrillatory activity. Basically, the atria are just quivering. They're not contracting the way they're supposed to. And because of that, the electrical signals going down, they're going down to the ventricles all over the place. That's why the rhythm is irregularly irregular. There's no pattern. The spacing between the QRS complexes is completely unpredictable. So when you hear a nurse say it's irregularly irregular, that's code for AFib, until proven otherwise. So basically, the atria are basically spazzing, sending hundreds of impulses at once. The AV node tries to slow it down, but it can't keep up. That's why the ventricles fire off randomly, giving you that chaotic rhythm that you see here. Now, the big problem is when the atria don't contract properly, blood sits in pools, especially in the left atrium. That pooled blood can form clots, and if a clot breaks off, it can travel to the brain, causing a stroke. That's why AFib patients are usually on anticoagulants like warfarin or apixaban. So the key thing here, no P waves, right? The atria are not contracting in sync. And then also that irregularly irregular rhythm we mentioned. The QRS spacing is all over the place. Makes sense. So the ventricles are firing normally, just at random intervals. So if you ever, again, if you ever see irregularly irregular rhythm or a patient on warfarin with palpitations, what are you going to immediately think? AFib. right? And remember, if the patient has any new or worsening symptoms like dizziness, chest pain, confusion, you get an ECG first. Don't just give meds. So just remember, in AFib, the atria quiver. The ventricles fire randomly and the rhythm has no pattern. So if it's irregularly irregular, think AFib. Um, let's talk treatment for AFib. Because this is where a lot of people will get tripped up. So um, with AFib, the heart's not pumping properly, so blood sits and pools, especially like we said in the left atrium. And when blood just sits there, it clots. And if that clot travels, stroke, right? So we have to do two things: fix the rhythm or control the rate, and anticoagulate to prevent clots. Now, there are two main anticoagulants that you'll see together in questions: heparin and warfarin. They both thin the blood, but they're used differently. So with heparin, think hospital, think fast. It's first line, it's fast acting, it works within seconds to minutes. The route is IV or sub-Q. That's why it's used inpatient, because we can control and stop it quickly. We monitor PTT levels. That's partial thromboblastin time. We want it 1.5 to 2 times the normal range, or roughly 46 to 70 seconds. If PTT is too high, stop the infusion. The blood's too thin. They could bleed. The antidote is protamine sulfate. So on NCLEX, if you see a patient on heparin with bleeding gums or black tarry stools or high PTT, stop the drip, call the doctor, and get ready to give that protamine sulfate. So just remember, heparin helps here and now. Warfarin works when they go home. That's the big difference between the two. Makes sense? Awesome. Well, that is all for today's free Zoom. I hope that you all enjoyed. We love when you participate, when you ask questions. Awesome questions that you guys ask. But I hope everyone enjoyed, and I hope to see you guys again next Wednesday evening. Okay, have a fabulous evening, everyone. Bye, guys.